associated with retinal astrocytoma. So retinal astrocytomas, they are actually hematomas, which are benign glial proliferation of tumors which arise from the retinal nerve fiber layer. So they can be isolated or most commonly associated with tuberous sclerosis. The other associations which have been documented are neurofibromatosis, retinitis pigmentosa, Usher's syndrome, Stargardt's disease, and gyrate atrophy. So it's one of the major criteria in the tuberous sclerosis complex diagnosis, and it's the most common ophthalmic manifestation, which is seen in 50% of the patients, and 30% of these are bilateral. So it's classified based on ophthalmoscopic features and OCT features. According to the morphological classification, there is type 1, 2, and 3, whereas type 1 is a well-circumscribed translucent gray-white lesion. Type 2 has calcification, also called mulberry type, and type 3 is also called mushroom type, which is a transitional lesion. According to the OCT findings, it's divided into 4 types. Type 1 is a hyperreflective thickening of the retinal nerve fiber layer. Type 2 is a dome-shaped elevated lesion with retinal disorganization and abrupt transition between the tumor and the normal retinal surface. Type 3 is also dome-shaped, but it has a moth-eaten appearance due to intralesional cavitation. And type 4 is an optically empty lesion. So the first case was a 31-year-old female who was diagnosed with tuberous sclerosis complex. She had no ocular findings, but she had systemic and imaging features consistent with tuberous sclerosis complex. So the fundus of the right eye showed a smooth, non-calcified, gray-white translucent lesion, and the left eye there was a mulberry-like lesion with glistening yellowish spherules of calcification. OCT of the right eye showed hyperreflective thickening of the retinal nerve fiber layer. So this is suggestive of a type 1 type of lesion in the right eye and a type 2 in the left eye. The second case was a 14-year-old female who was diagnosed as tuberous sclerosis. Fundus lesion of the right eye showed smooth, non-calcified gray-white lesion in both the eyes, and OCT showed homogeneous hyperreflective dome-shaped thickening. The third case, which was 20-year-old male, also with tuberous sclerosis, he had a unilateral lesion, which was a well-circumscribed opaque lesion, this is a transitional type 3 lesion. The OCT showed a significantly elevated lesion with intralesional cavitation with posterior shadowing. The fourth case was a 37-year-old female who also had tuberous sclerosis and a unilateral presentation. There was a smooth, non-calcified gray-white lesion, and the OCT was limited by the site of the lesion. The fifth patient was a 16-year-old male who also was diagnosed as tuberous sclerosis complex. He had well-circumscribed, smooth, non-calcified lesions in both the eyes, and the OCT showed the fourth type of lesion, which is an optically empty lesion with hyperreflective thickening anterior to the lesion. So all patients with tuberous sclerosis complex should ideally have a complete ophthalmic examination and a OCT for classification. So the lesions which are classified as type 2, they are commonly associated with cutaneous fibrous plaques. Those which are classified as type 3 are associated with subependymal hematomas, and type 4 is associated with pulmonary lymphangiomatosis. So each type has a systemic association. So spectral domain OCT can be used to facilitate the detection and the follow-up of retinal astrocytic hematomas.
So what are the common problems with retinal astrocytoma?
Most of the cases are benign and they do not increase in size, but the lesions which are either juxtapapillary or have a macular location, they tend to have progression and show aggressive behavior such as retinal traction, schisis cavities, accumulation of subretinal fluid, and exudative retinal detachment, and cystoid macular edema.
Was there any miss in your diagnosis clinically and OCT wise?
Yes. In a few cases, the morphological classification and the ST-OCT classification did not correlate.